Okay, can I start?
Good evening, consultants and fellow colleagues. Welcome you all to today's presentation on supraventricular tachycardia. Our colleague, Dr. Kanisi Philomena Chidima, will take us through the presentation. Dr. Chidima, please, your audience.
Okay, good evening, consultants, my seniors and colleagues. The presentation this evening is on supraventricular tachycardia, and I will use the following outline: introduction, epidemiology, classification. The next slide, types of SVT, and then management. As a way of introduction, supraventricular tachycardia, SVT in short, is defined as a tachycardia in which the driving circuit or focus originates, at least in part, in tissues above the level of the ventricle. That is the sinus node, the atria, the AV node, or the His bundles. In the absence of a bundle branch block, there is intact conduction to the ventricles via the right and left bundles, leading to a narrow and normal appearing QRS. Therefore, these arrhythmias are also often called narrow complex tachycardia. So the term SVT literally indicates tachycardia atrial rates of greater than 100 beats per minute at rest. The mechanism of which involves, which I have just said, His bundles and above, and is used to describe all types of tachycardia besides atrial fibrillation and ventricular tachycardia, according to the last ESC guideline. Usually requires the atrial tissues or the AV nodal tissues for initiation and then maintenance. The expression is variable from asymptomatic or mild symptoms to severe symptoms. As a way of epidemiology, the prevalence is about 2.25 per 1,000 persons with an incidence of 35 per 100,000 persons per year. Women are affected 2 times more than the men, and persons older than 65 years have a 5 times greater risk than younger people. The AV ventricular nodal reentrant tachycardia is more common in middle-aged people than the older patients, while adolescents are more likely to have SVTs with accessory pathways. Then epidemiology continues. Incidence is increased in smokers and patients with a history of myocardial infarction and heart failure. Women are more likely, as I have already said, affected by the AVNRT, while men are more likely to be affected by AVRT. In women, increased frequency of episodes have been associated with monthly cycles and pregnancy. Then the next slide is talking about the conduction pathway of the heart. So as a brief summary, the SA node, we know that is the site of initiation of the electrical activities of the heart, which then moves down to the AV node, to the bundle of His, the left bundle branches and the right bundle branches, and finally to the terminal Purkinje fibers. And this is the normal flow of electrical activity in the heart. So any form of obstruction at any point or aberrancy will give a disorganized electrical system. So we have mechanisms of cardiac arrhythmia, and the mechanisms are, we have one on the disorders of impulse formation and then the conduction. So there might be some abnormality in the formation of the impulse, and then the other parts could come from the impulse conduction through the pathways that I previously described. And the abnormalities that occur as a result of impulse formation are, the mechanisms are: one, automaticity, altered normal automaticity. Then we can have abnormal automaticity. We can have triggered activity and then delayed after depolarization and early after depolarization. And then for reentry, we can have anatomic reentry and then functional reentry. So as a way of pathophysiology, tachyarrhythmias occur as a result of three main mechanisms, which I have already described, but a little description of them. They can occur as a re-entry, which is the most common, and then enhanced or abnormal automaticity and triggered activity. Then the continuation of the pathophysiology. Then the reentrant arrhythmias. These arrhythmias, they sustain themselves by continuously following a revolving pathway that comprises of two limbs. The one that takes the impulse away from the heart, while the other takes it back to the origin. And for that re-entry to exist, an area of slow conduction must occur, and each limb must have a different refractory period. So when we go further to the NRT and then AVRT, we'll see that where we have either the slow fast or the fast pathway, and they have different refractory period. Then continuation of the pathophysiology. The second mechanism, automaticity, refers to spontaneous and often repeated firing from a single focus, which may either be atopic or may originate in the sinus node. And this mechanism comprises of two subcategories. We have the enhanced automaticity, defined as a focus that fires spontaneously and may originate in the sinus node, either the subsidiary pacemaker in the atrium, including the eustachian ridge, the Bachmann bundle, coronary sinus and AV valves, or the AV node, or the His-Purkinje system and the ventricles. Then we can also have abnormal automaticity. This is usually secondary to a disease process causing alterations in ionic flow that produces a less negative resting diastolic membrane potential. So at this point, the cell can be activated or the refractory period will be shortened, that will lead to another firing of the. Then the pathophysiology continued. The third mechanism, we talked about the triggered arrhythmias. And these triggered arrhythmias, that they depend on oscillations in the membrane potential that closely follow an action potential. So in the absence of a new external electrical stimulus, these oscillations, or after depolarization, they cause new action potentials to develop. Thus, each action potential results from the previous action potential. So these arrhythmias can be produced by early or late after depolarization. So the clinical presentations, we need to take a detailed history, the age of the patient, sex and onset of symptoms, the duration of symptoms, then other symptoms of like breathlessness, and then heart failure also can occur from recurrent supraventricular tachycardia, and this can lead to tachycardia-induced cardiomyopathy. And the most common symptoms that have been expressed by patients with this supraventricular tachycardia are palpitations and dizziness. Other symptoms include chest tightness, shortness of breath, syncope, nausea, and diaphoresis. So clinical presentation, as I've said, can range from mild to severe symptoms. Then as a way of initial evaluation of patients with supraventricular tachycardias, as recommended from them by the ESC guideline, they recommended these standard things to be done, which include one, history, detailed history, physical examination, and a 12-lead ECG. Then the full blood count, complete blood count, biochemistry profile, and thyroid function test. Then an ECG during tachycardia should be sought if it is possible, because it is during those periods that the ECG will likely be positive in these patients. And then transthoracic echocardiography, optional exercise tolerance testing, and then 24-hour ECG monitoring or an implantable loop recorder. Then EPS, electrophysiological studies, should also be considered for a definite diagnosis, especially when catheter ablation is anticipated. So we have the conventional classification of the supraventricular tachycardias, is divided into the atrial tachycardias, like we have the sinus tachycardia, We have under the sinus tachycardia, we have the physiological sinus tachycardia, the inappropriate sinus tachycardia, sinus node reentrant tachycardia. We have the focal atrial tachycardia and multifocal atrial tachycardia. Then the AV junctional tachycardia, we have the AV NRT, we have the typical and atypical. And then we have the non-reentrant junctional tachycardia and then AVRT, the orthodromic and then the antidromic. Then the next slide will tell us the differential diagnosis. They are just what I have just said. We have the narrow complex and then the wide complex. Then as a way of assessment of a patient with a narrow complex tachycardia, as also recommended by the ESC guideline. So it follows an algorithm where we have a narrow QRS tachycardia showing that the QRS is less than 120 milliseconds. And if the rhythm is regular, we have a regular tachycardia, yes. Next thing we'll look at is, do we have any visible P wave? If there are no visible P waves, we think of a typical AVNRT, focal tachycardia. Then if we have a visible P waves, we'll think of the atrial rate. So when we look at the atrial rate, is it greater than the ventricular rate? If it is greater, we are looking at the atrial flutter, focal atrial tachycardia. And then if the atrial rate is not greater than, if ventricular rate is more than the atrial rate, then that will also go to high septal ventricular tachycardia and the AVNRT, though these ones are rare. And then if the ventricular rate is not greater than the atrial rate, we consider the RP interval. This will also try to buttress down the more typical diagnosis. So if we have short RP less than, that is, the RP is less than the PR interval, thereby RP is less than 90 milliseconds, we are thinking of the typical, that is the short, the slow, fast AVNRT, and then the focal atrial tachycardia and others. So the ECG shows the typical, we can see atrial tachycardia with narrow QRS complex. Okay. And the second one, we have multifocal atrial tachycardia with different P wave morphology. And the second, ECG. Then the acute management in the absence of established diagnosis for narrow complex tachycardia. We will consider, first of all, is this patient hemodynamically stable or is the patient unstable? This guides the next step. If patient is hemodynamically unstable, we move straight to synchronized cardioversion, and this is level 1B in the ESC guideline recommendation. Then, if the patient is stable, we'll go straight to vagal maneuvers. And if after repeating one or two vagal maneuver and is ineffective, we'll go to AV nodal blockage, that is IV adenosine, and then further. And these vagal maneuvers, they include different techniques used to stimulate the receptors in the internal carotid arteries. So this stimulation causes a reflex stimulation of the vagus nerve that will result in release of acetylcholine, which may in turn slow the heart rate and then the parasympathetic nerve. Okay, then move 2 slides. That is after the next one. It's just the summary of key ECG criteria that will suggest ventricular tachycardia and the other. So we'll now go straight to the specific types of supraventricular tachycardia. Number one is the sinus tachycardia. It's defined as sinus rate greater than 100 beats per minute. Is usually physiologic response activated when the body requires a higher heart rate to meet metabolic demand. The onset and termination is gradual, and P wave is identical to normal sinus P wave. So in here, P wave is positive in lead 1 to AVF and biphasic in V1. So we have sinus reading. And the RP relationship is long. Then the next slide tells us the causes of physiological, the causes of sinus tachycardia that could be physiological or pathologic. The physiological causes are emotion, physical exercise, pain, pregnancy. Some pathological causes, anxiety, panic attack, anemia, fever, dehydration, hyperthyroidism, pheochromocytoma, hypoglycemia. There are also some drug causes of sinus tachycardia: epinephrine, norepinephrine, dopamine, dobutamine, atropine, and the beta blocker withdrawal. Then illicit drugs like amphetamine, cocaine, crack, and then others like caffeine and alcohol. So the next slide shows us the sinus tachycardia. This has a sinus of heart rate of about 150 beats per minute. So the next also, this is 100 beats per minute, showing us the sinus tachycardia with similar P waves. So treatment of a sinus tachycardia, attempting to slow the heart rate pharmacologically can be detrimental. Why? Because it counteracts the compensatory mechanism provided by the tachycardia. So sometimes physiologically, this tachycardia occurs as a compensatory mechanism. Therefore, management usually focus on treating the underlying cause of the sinus tachycardia. If the patient has fever, anemia, or all that, it should be corrected. Then beta blocker, calcium channel blocker, ivabradine in case of inappropriate sinus tachycardia could also be used. Then in severe cases, sinus node radiofrequency or surgical ablation may be indicated. So this therapy for sinus tachycardia, as recommended by the ESC guideline, the sinus tachycardia, the first recommendation, which is 1C, is treatment of reversible causes. Then, if that is ineffective, we can now go to beta blockers, ivabradine. Then, if the tachycardia is still symptomatic and recurrent, we can, and drug therapy is still desirable, we go down to verapamil or the diltiazem, that is the non-dihydropyrimidine calcium channel blockers. But if the drug therapy is not desirable, we can go to use catheter ablation. This is class 2A recommendation. Then we have inappropriate sinus tachycardia as the next form. So this is defined as rate of 100 beats per minute at rest or minimal activity that is inappropriate to physical, emotional, or pathological or pharmacological stress. So this is when we have a tachycardia that is not commensurate with whatever is precipitating it. So mechanism is poorly understood, but has been associated with gain of function of HCN4 channel in familial form. And still what I've just said, the mechanism of inappropriate sinus it remains poorly understood. And it tends to be caused by a lot of multifactorial, that is a lot of factors. For example, dysautonomia seen in diabetic patients, neurohormonal dysregulation, and intrinsic sinus node hyperactivity. So recently, like what I said before, HCN4, recently a gain of function of mutation of the pacemaker hyperpolarization activated cyclic nucleotide gated 4 channel, HCN4 channel, has been reported in familial form of inappropriate sinus tachycardia. There is also evolving evidence that immunoglobulin G anti-beta receptor antibodies are also found in patients with inappropriate sinus tachycardia. The prognosis of inappropriate sinus tachycardia is generally considered benign, and the arrhythmia has not been associated with tachycardia-induced cardiomyopathy. Okay, the next form of is sinus node reentry. This is uncommon reading and accounts for less than 5% of supraventricular tachycardias. It uses the sinus node or perinodal tissues as a critical part of the reentrant circuit, producing P waves that is identical to those seen during normal sinus reading. Unlike sinus tachycardia, sinus node reentry is initiated by an atopic beat rather than a physiological stimulus and possesses the characteristics typical of a reentrant circuit. Therefore, this it begins and ends abruptly and respond to vagal maneuvers and pharmacological intervention by termination rather than slowing down. So the sinus nodal reentrant tachycardia involves the SA node. Okay. So the ECG characteristic, we have ECG P waves are similar to those of sinus P waves. And then we made the diagnosis using the ECG and we confirm it because it could be confusing. We confirm it using the electrophysiological studies. Then the next entity is the postural orthostatic tachycardia syndrome. Is a syndrome characterized by an increase in heart rate greater or equal to 30 beats per minute when standing for 30 seconds and in the absence of orthostatic hypotension, that is greater than 20 millimeter drop in systolic blood pressure. So this, in this case, tends to have a variability of a heart rate of greater or equal to 30 beats per minute when standing for greater than 30 seconds, provided this patient doesn't have orthostatic hypotension. We'll term it postural orthostatic tachycardia syndrome. The prevalence is 0.2%, and it has increased frequency in females and adolescents 15 to 25 years. Usually, there is spontaneous recovery in about 50% of patients in about 1 to 3 years. So it's a diagnosis of exclusion. And then as a way of management, we have non-pharmacological management, that patient lifestyle modification. I will ask patient to increase salt and water intake and graded exercise. Then the pharmacological management, patient can be given midodrine. Midodrine is alpha-1 selective adrenergic agonist, which increases peripheral resistance and venous return, or low-dose propranolol. All right. Then the next entity is the focal atrial tachycardia. We have organized atrial rhythm that is greater than 100 beats per minute, initiated from a discrete location and spreading over both atria and ventricle. Spreading over both atria. The ventricular rate varies depending on the AV nodal conduction. So 12-lead ECG during episodes is critical and it helps in the diagnosis. So depending on the rate of the tachycardia, the P wave may be hidden in the QRS complex. And particular site for the focal atrial tachycardia is the crista terminalis, the mitral and tricuspid annulus, and within the pulmonary veins, superior vena cava, and the coronary sinus musculation. The essentials of the diagnosis is the onset of the focal atrial tachycardia. The onset and termination are sudden. The next slide. Heart rate is about 100 to 180 beats per minute. The P wave, we have distinct P waves that differ from the sinus P waves. And then the RP relationship is long. Then the next slide, the focal atrial tachycardia, there are some clues that can help us to determine the actual location that this tachycardia is coming from. So when we have a negative P wave in V1, shows us that it's coming from the lateral right atrium. And then negative P wave in lead 1 and AVL, it shows it's coming from the left atrial origin. Then if we have the negative in the inferior leads, it shows that the origin is a bit caudal. Then the treatment, the acute therapy, beta blockers and calcium channel blockers can be used. And then class 1A, 1C, and 3 drugs, antiarrhythmic agent, can be used to increase the the refractories. And then amiodarone can also be used for cardioversion. So we have the ECG. When we look at the ECG, the next slide will show us the ECG. I was talking about the focal atrial tachycardia. So when we look at C shows negative P wave in V1. And when we have negative P wave in V1, it's trying to tell us that it's from lateral right atrium. Then if we look at a lead, they're not so clear, lead 1 and AVL, and we have a negative P wave there coming from the left atrial origin. Then the next slide will tell us about the acute management of focal atrial tachycardia. The next slide. Still based on the ESC guideline, the first consideration is the hemodynamic stability of the patient. In unstable patients, the guideline is always to move straight to synchronized cardioversion, which is level 1B recommendation. Then, if patient is stable, we'll give adenosine, which is an AV nodal blocker. Then, if the adenosine is ineffective, we'll move down to the verapamil and then the beta blocker. Then, the next slide. Then, for chronic treatment of focal atrial tachycardia, if the tachycardia becomes recurrent or incessant, the next step could be to, if yes, then we'll go straight to catheter ablation, which is level 1B recommendation. Then, if the catheter ablation is not tolerated or ineffective, we can move back to amiodarone and others. Okay, the next slide. Another entity is the multifocal atrial tachycardia. The multifocal atrial tachycardia, there are rapid, irregular readings with at least 3 distinct morphologies of P wave on the surface ECG. The heart rate is up to 150 beats per minute, and we have variable PP, PR, and RR intervals. The multifocal atrial tachycardia is associated with underlying conditions which include pulmonary disease, pulmonary hypertension, coronary artery disease. Then the next slide is, okay, I've already said that it's related to pulmonary disease, and in about 60 to 85% of cases, the multifocal atrial tachycardia is found in people with pulmonary disease or those with chronic obstructive pulmonary COPD, exacerbations being the most common. Then, in addition, multifocal atrial tachycardia is precipitated by respiratory failure, acute decompensated cardiac function, and infection. It has also been multifocal atrial tachycardia has also been reported to be associated with hypokalemia, hypomagnesemia, hyponatremia, pulmonary embolism, cancer, valvular heart disease, and can also occur in post-operative settings. So the next slide will show us the multifocal atrial tachycardia, where we have at least 3 different morphologies of the P wave. Look at the arrow, shows different morphologies of the P wave. Likewise, on the second ECG. Then the next slide tells us a recommendation for therapy of multifocal atrial tachycardia according to the ESC guideline. The recommendation for acute therapy. 1, it is recommended that treatment of an underlying condition is recommended as the first step if feasible. So if a patient has the COPD or other pulmonary diseases, it needs to be tackled. Then and it's a class 1 and level C recommendation. Intravenous beta blockers or IV non-dihydropyridine calcium channel blockers, verapamil and diltiazem, should also be considered with a class of 2A and level B. Then the chronic therapy for multifocal atrial tachycardia. For chronic therapy, we use oral verapamil or diltiazem should be considered for patients with recurrent symptoms, symptomatic multifocal atrial tachycardia, in the absence of heart failure with reduced ejection fraction. Then a selective beta blocker should be considered for patients with recurrent symptomatic multifocal atrial tachycardia. Then the next recommendation, still on the same class and class 2A, AV nodal ablation followed by pacing, preferably biventricular or His bundle pacing, should be considered for patients with left ventricular dysfunction due to recurrent multifocal atrial tachycardia refractory to drug therapy. Okay. Then the next entity is the atrioventricular nodal reentrant tachycardia. This is the most common form of paroxysmal supraventricular tachycardia, representing 60% of cases referred for catheter ablation. It most commonly manifests in the second to fourth decade of life and is commoner in women. It is often well tolerated, but rapid tachycardia, especially in the elderly, may cause angina, pulmonary edema, hypertension, or syncope. It is not usually associated with structural heart disease. The next slide, the mechanism of AVNRT is re-entry involving the AV node and the perinodal atrium. Then this is made possible by the existence of multiple pathways for conduction from the atrium into the AV node and these are capable of conducting in two directions. So the next slide tells us about the dual AV nodal pathways during sinus reading in AVNRT. So during normal sinus reading, AV conduction occurs as follows. The normal sinus beat enters the AV node and the impulse travels down both the fast and the slow pathway. So this AVNRT has different pathways. It has the slow, fast, and then the fast slow pathway, and then the slow pathway. We have the atypical and then the typical pathway. So this normal sinus beat enters the AV node and the impulse travels down both the fast and the slow pathways. Now, this impulse traveling down the fast pathway will reach the His bundle first and then creating a refractory wake. That is, it reaches the His bundle, reaches its refractory period. Then the impulse now traveling down the slow pathway is extinguished when in the area of the final common pathway, it runs into refractory wake of the impulse that has traveled down the fast pathway. Then the advent of ultra-high density three-dimensional mapping has made it possible to detect this site of collision during the sinus rhythm in patients with dual AV nodal pathway. So it's just trying to tell us in patients with this dual AV nodal pathway, the fast pathway runs first, reaches this refractory period, then the slow pathway moves, and at the point that it jams the fast pathway, there is the collision of this both of these pathway, and then this ultra high density three-dimensional mapping will make it possible to differentiate or to make this known. Then we have the typical AVNRT, which is the slow fast pathway. Approximately 80 to 90% of patients with AVNRT presents with what is called the common form of the arrhythmia. The common form is called the typical AVNRT or the slow fast AVNRT. And the typical AVNRT usually initiates as follows. That is what happens in typical AVNRT. A premature atrial complex, which we call either premature supraventricular beat, arrives at the AV node when the fast pathway is in its refractory period. So thus, antegrade conduction down the fast pathway is blocked. So the fast pathway has run, moved to the refractory period. Then, while the slow pathway, the premature beat that is coming now moves antegrade and then meeting that fast pathway. Thus, that the antegrade conduction than the fast pathway is blocked. So if the premature beat arrives in a specific time window, that is a critically timed or premature, so the slow pathway with a shorter refractory period than the fast pathway is available for conduction to the ventricle. Then the premature beat conducts via the slow pathway through the final common pathway to the bundle of His. As a result of this, the PR interval of the premature beat will be longer than the normal, that is the conducted through the fast pathway. Then continue. So if the fast pathway has recovered its excitability by the time the slow pathway impulses reaches the distal junction of the two pathways, the impulses can conduct retrograde up the fast pathway. So this circuit may then become repetitive with antegrade conduction back down and slow pathway and retrograde conduction up the fast pathway. This results in a sustained tachycardia. So the picture, this it describes what I just said, the mechanism of re-entry in this low fat AV NRT, and we have the effective refractory period. So the ECG below also describes what happens in the AV NRT, where we have the retrograde. Okay, then the next slide, the atypical AVNRT. Up to 20% of patients with AVNRT have uncommon forms of arrhythmia and is referred to as atypical AVNRT. So in the atypical form, which we call the fast-slow pathway, the antegrade conduction can occur down the fast pathway with retrograde conduction up the slow pathway. So this is referred to as the fast-slow AVNRT. So in a typical AVNRT, retrograde atrial activation occurs long after ventricular activation, resulting in a P wave that comes so late after the QRS complex. And it appears to be occurring shortly before the next QRS complex. So this pattern resembles what is seen in atrial tachycardia. In such cases, a electrophysiology study may be required to define the mechanism of the arrhythmia. So as I said, the fast-slow is an uncommon pathway, accounts for 10% of AVNRT, associated with fast AV nodal pathway for anterograde conduction and slow AV node pathway for the retrograde conduction. So because of the relatively long ventriculoatrial interval, the retrograde P wave is more likely to be visible after the corresponding QRS. And so in the fast-slow AVNRT, known as the atypical form, the P wave tends to be distinct, while in the slow fast, the P wave is buried in the QRS complex. So some patients, the next slide, some patients have multiple slow pathways resulting in slow AVNRT variants, in which both the antegrade and the retrograde limbs of the circuits, they utilize slow AV nodal pathway. Then we also have another entity. Rarely, during the AVNRT, conduction through the reentrant circuit is so slow that the heart rate is less than 100 beats per minute can occur. Then by definition, this is not a tachycardia. So despite the absence of tachycardia, patients can be symptomatic and may be treated with a slow pathway ablation. So this arrhythmia sometimes is referred to as AV nodal reentrant arrhythmia. Okay, that's the description I just made in the past about the slow and the fast. Then the ECG findings in AVNRT. There are several ECG features that are helpful in confirming the diagnosis of AVNRT. The ventricular rate The ventricular rate is generally between 120 to 220 beats per minute. Usually, AVNR routine has an abrupt onset following a premature atrial complex. So if the initiation of the tachycardia is captured on a tracing, the tachycardia often begins with a premature atrial complex with sudden prolongation of the PR interval. Then the relationship, the next slide talks about the relationship between QRS complex and P wave. Now, because of the relationship between the QRS complex and the following P wave, typical AVNRT is referred to as the short RP tachycardia, while the atypical AVNRT is the long RP tachycardia. And the typical AVNRT, the retrograde atrial activation and antegrade ventricular activation occur almost simultaneously, thereby obscuring the P wave. That is, the P wave is embedded in the QRS complex. So the P wave, therefore, is usually buried within or fused within the QRS complex. So sometimes a component of P wave is often evident slightly after or less commonly before the QRS complex. So when the P wave occurs shortly after the QRS complex, the fused waveform can produce a pseudo R, that is a second R wave in lead V1 and a pseudo S in inferior leads. Okay, the next slide is just a summary of what I just talked about, the typical AVNRT, and then the relationship where the RP interval is less than the PR interval on the ECG due to slower conduction than the ECG criteria. Then the next slide talks about the classification of the AVNRT tachycardia types. Okay, let's go to the next one. So we'll move 2 slides above so that we have the typical ECG that is showing us the slow, fast AVNRT, that the P wave is embedded in the QRS complex. So you can see that we don't have any P wave in the first one. Then we have the fast, slow AVNRT, the last. You can see distinct P waves. Then we have short RP interval, while the other one has a long RP interval. Then the management of AVNRT, we have acute management and long-term management. Okay, we'll still see the slide showing us the ESC guideline. For the acute management, we have the vagal maneuvers and then adenosine, which is an AV nodal blocker. Then we also have catheter ablation. So for management of AVNRT, if patient out of hospital, probably patient is not in the hospital setting. If yes, we use vagal maneuvers. Then if no, and this patient is in the hospital, we also consider the hemodynamic stability of the patient. If the patient is hemodynamically unstable, we do synchronized cardioversion, which is a level 1B recommendation. Then if patient is stable, vagal maneuver. If it is ineffective, we use IV adenosine. Then we can move down to verapamil, diethiazem, and then the beta blocker. If these are ineffective, patient can still go straight to synchronized cardioversion. Then for symptomatic and recurrent AVNRT, these patients benefit, according to the ESC guide recommendation, catheter ablation. So if no, that is, it's not symptomatic and recurrent, we'll go for drug therapy. Then if the drug therapy is ineffective, we can still go straight to catheter ablation. Then the next entity is the non-reentrant junctional tachycardia. It occurs from abnormal automaticity at the AV node or proximal to the His bundle. This can be congenital in children or from post-infant heart surgery and can also be seen in adults with normal hearts. So the non-reentrant junctional tachycardia shows narrow QRS complex with a short RP interval or AV dissociation. Oh, okay. Then the treatment. Patients benefit from propranolol, verapamil, and then other antiarrhythmic agents. Amiodarone can also be used in infants to prevent post-op junctional reentrant tachycardia. Okay. Then the next slide is another form we call the AVRT, atrioventricular reentry tachycardia. It's a form of paroxysmal supraventricular tachycardia that occurs in patients with accessory pathways, usually due to formation of a reentry circuit between the AV node and the accessory pathway. So the ECG features depends on the direction of the conduction, which could be orthodromic or antidromic. So the next slide shows us the pictorial representation of the AVRT. We can see the orthodromic. The orthodromic goes through the normal SA node to the AV node, while the antidromic goes through the accessory pathway before reaching the AV node. Thus, it tends to toll a longer path, causing cell-to-cell depolarization and wide QRS complex. In orthodromic AVRT, anterograde conduction is via the AV node, producing a regular narrow complex rhythm in the absence of pre-existing bundle branch. But if there is a coexisting bundle branch, the QRS complex will be wide. While in antidromic AVRT, anterograde conduction is via the accessory pathway, producing a regular wide complex reading. And this can be difficult to distinguish from ventricular tachycardias. So in orthodromic AVRT, anterograde conduction occurs via the AV node, resulting in normal direction of the ventricular depolarization. This can occur in patients with a concealed pathway. That is, the orthodromic can also occur in patients with a concealed pathway, accessory pathway. For example, the accessory pathway that they conducts only in retrograde direction, and it is not evident on sinus reading in ECG. Okay, this is just what I have described. The AVNRT having two limbs, the AV node, his Purkinje system, and then the accessory pathway. Okay. Okay, then this is a description of what happens in the orthodromic and then the antidromic AVRT. The antegrade conduction through the atrioventricular node will give us a normal QRS duration, no delta wave, and then retrograde P wave after QRS complex, while the antidromic that goes through the accessory pathway, then before now going retrograde, there we have wide QRS complex with a delta wave. P wave is rarely seen. Then if P wave is visible, it is retrograde and occurs just before the QRS complex. Then the accessory pathways, it has a faster conduction rate because of the sodium current-like myocardial cells that are in the accessory pathways. Okay. Then the next slide, okay. Okay, this is just what I've described. The orthodromic is more, greater than 90% of the AVRT. And 20 to 30% of all sustained supraventricular tachycardia is the orthodromic AVRT. And the tachycardia is usually about 150 beats per minute. And the ECG features, we have RP interval is constant, narrow KRS complex. Then ST segment the depression can also occur. Okay, the next two slides, we'll see the ECG features of the antegrade and the retrograde. Okay. Here we can, in the second one, the B wave is not discernible and it has about 180 with rate of 180 beats per minute. Okay, we'll move down. The antidromic AVRT, 3 to 8% of patients with Parkinson-White syndrome have a antidromic AVRT. The retrograde limb is the AV node his Purkinje, while the antegrade is from the accessory pathway. And which I've just described, it has wide QRS and then RP interval that is difficult to assess. Okay, I've already described it. Okay. Okay. Then the treatment of antidromic AVRT. The reading can be very difficult to distinguish from ventricular tachycardia. And if there is any doubt, we should presume a diagnosis of VT and treat accordingly. In stable patients, drug therapy should be targeted at the accessory pathway. Procainamide, that is class 1 antiarrhythmic agent, will be our first line antiarrhythmia to be used. Then ibutilide and amiodarone are the second line. Now, the re-entry circuit involves the AV node. Why can't we use AV nodal blockage in treatment of this antidromic SVT, AVRT? Antidromic AVRT is often associated with a rapidly conducting anterograde accessory pathway. So AV blockage through the adenosine may interrupt the re-entry circuit. But as stated above, with administration of any nodal blocking agent, there is a small risk of inducing atrial fibrillation. And if this occurs, it will likely precipitate cardiac arrest due to rapid conduction VRD. So if we give, because the accessory pathway does not go in the antidromic, does not go through the normal AV nodal pathway, it goes through the accessory pathway before moving back. So if you block the main pathway, which is the AV node, what happens is that the accessory pathway will keep firing, and then leading to atrial fibrillation that might precipitate cardiac arrest. So in patients with antidromic Wolff Parkinson White, we do not give AV nodal blockers for them. So this Wolff Parkinson White syndrome, okay, I've just described it as we talked about the antidromic. And the main characteristics, it has short PR interval, less than 120 beats per minute, then slowed upstroke and widened QRS complex. So this is the ECG that Wolff Parkinson White ECG. We can see the short PR interval, the slowed upstroke, and the widened QRS complex. So, and there's something I got about localizing the accessory pathways. There are various ways one can localize the accessory pathways. These are just asking. So the ECG features. Please let me change location. Okay, sorry for the interruption. So in management of AVRT, The next slide, according to the ESC guideline, if the AVR route is symptomatic and recurrent, if yes, we go straight to catheter ablation. If no, we use drug therapy. Then for autodromic AVRT, we use the thiazem, that is the and verapamine. Then for if it is not autodromic, that is the antidromic, we don't use AV nodal blockage. We use the antiarrhythmic agent like flecainide and then propafenone. Okay, thank you very much. This is the end of my presentation. Thank you so much.
Thank you very much for the presentation. At this point, we want to invite questions and contributions from our colleagues on the call. Then we'll have the consultants and fellows on the call also come in with their contributions. So please, questions, colleagues going for exams, any contributions, questions, clarification? Hello?
Chief, we can hear you.
Any contributions, please? Questions, clarifications?
Hello, good evening. Please,
Good evening.
I have a tiny question, please. Just to ask the how. In the presentation, she said Wolff Parkinson White syndrome. It's 3 to 5% is antidromic. My question is, can Wolff Parkinson White be autodromic? Thank you. Anybody in the house can answer. I just need a little clarification. Thank you.
Dr. Yeah, well done. So what is autodromic? What do you understand by autodromic? Before we will now go to WPW, so that you just get it clear.
Okay, Chief. I understand orthodromic to be when the impulse is going from the AV node first and stimulates the ventricles and returns back through the accessory pathway. While in antidromic, you have the impulse going through the accessory pathway first, stimulating the ventricles and returns back through the AV node. So I know Wolff Parkinson White is actually an antidromic AVRT. But we're just wondering, is there any Wolff Parkinson White that can?
So what?
Okay, sorry, sir.
When you go to the ECG now, okay, so what do you think is the ECG representation of autodromic and antidromic? So just the QRS complex. And why?
ECG representation of QRS complex. Okay. The QRS complex in antidromic will be broad because of it's going into the accessory pathway into the ventricles. So it's going to do like a cell-to-cell depolarization. So it's going to take a longer time to depolarize the ventricles. So you have a broad complex. You have a broad QRS. Unlike if it's orthodromic, it's going through the normal pathway. It's going through the normal AV node, the bundles, Purkinje fiber. So it's going through the normal pathway. So in orthodromic, you should have it shouldn't be broad except you now have aberrancy.
Okay. So is it possible, or I don't know if you have seen any WPW that has a very narrow QRS complex without slurring?
No, Chief, I've not seen, sir.
So if Wolff Parkinson White occurs as orthodromic, meaning it passes through the AV node before it goes through the accessory pathway, would that now be Wolff Parkinson White?
Okay, Chief, no, it won't be Wolff Parkinson White again. It will be narrow complex.
Okay. All right. I think so. That's what I'm thinking too with you. I don't know if anybody has any other option for the question shared.
Thank you, sir.
Yeah, welcome. So, Dr. Eugene, normally, right, if people really prepare for the presentation, or maybe we have the topics that will be taken as a timetable, maybe people will read ahead, and when they are presenting, it may stimulate more questions and interaction. Sometimes some persons are being exposed to this presentation for the first time after they have read it maybe in the past. So it's not easy to generate questions. So that's why you're seeing the selective mutism. It's not deliberate. So I don't know if we can have timetable of curriculum presentation ahead so that people can read and have it. Okay, so that we can be fast and go to MCQ.
Yeah, but we have the curriculum topics have already been posted on the page way ahead, and I've been sending reminders.
Wow.
So it's been on the page since day one before we started.
Oh, wow. Sorry. That means the reading before the presentation is not done that much. Or you said that we understood it completely or never understood it. So, Larry, do you want to say something?
Chief of OP, thank you. Thank you for the lucid presentation. I only want if clarification could be done concerning the Wolff Parkinson White that we have the type A and type B. Is there any significance as regards to its management, or is there anything special as regards to this classification? Thank you. I hope I'm audible.
Yes, you're audible.
Okay, Chief, sorry, good evening. I just want to say something about what you said. I don't know if I can go ahead. Hello, can you hear me?
Yes, sir. Yes, ma'am.
Please go ahead.
Okay. You're asking why do we need to differentiate if it's type A or type B, if it affects the management in any way. I don't know if that's the question you're asking. Hello?
Yeah, very correct. And the components like that. Thank you.
Okay. So the only time I think is very important is if you're going to do some form of ablation for that patient, because it's not just knowing type A, it belongs to the left side. You can further localize it. Is it left anterolateral, anteroseptal, posteroseptal? You can further localize it from the ECG to know exactly where that tract is and target it during EPS to check if that tract is actually there and ablate. So it can help you when you're ablating to know where to go to check for the tract. Unlike if you don't differentiate if it's between A and B. If we say B, okay, right-sided, we can still further differentiate. Are we looking at posteroseptal on the right? So when you now differentiate that, you can exactly go to that point and say, okay, it will be likely here during EPS study and ablate. So that's why I think it's important. Thank you.
All right, thank you.
Thank you very much, Dr. Flomina, for the presentation. We are grateful. Most of these things requires going back and clarifying it in our minds. Can get confusing at times, but I believe if we continue discussing, solving the question, it comes in the questions too. So whilst if we get a question on it, then we remind ourselves and try and clarify which one is which. Thank you very much. On that note, if we don't have any other comments from colleagues or consultants on the call, we'll go to the MCQs.
All right. Sorry, I went off briefly, Dr. Eugene. Let me just make a few comments before we move to the MCQ. I want to say a big thank you to Dr. Philothea Ikenisi. From my experience, I must applaud this year badge, Dr. Eugene, for the curriculum presentation. You guys have been so excellent. Like, I'm enjoying it all over again as though I'm learning cardiology afresh. And today's presentation on SVT, to me, it's the gold standard. ESC, American Cardiac Society, and NCS should adopt this presentation as a standard for SVT. So thank you so much, Philothea. It was very detailed. It has almost everything. I appreciate you specifically for spending time to make this presentation very elaborate. Anybody going for exam, you don't need to open any textbook to read SVT. You just need to plead with Philothea to give you the slides so that you can go through it. Having said that, when I went for exams, the management of SVT was one of our oral stations. And specifically, Dr. Oga was the one manning that station. And he will paint a scenario for you that suggests an SVT with hemodynamic compromise and ask you to manage it. And then you say, if there's no hemodynamic compromise, what would you do? Now, if you go through what she said, she gave the answer correctly. But for me, when I entered that same station, he further asked some specifics, which I feel it may just be part of the marking scheme, because when I gave the answers, it was ticking. So if you could get it up to the point of what she gave, excellent. She did it very beautiful. And he will go ahead to ask you, how do you give adenosine, the dosages, if you've seen adenosine in your lifetime, how is it preserved and stuff like that. So it's an examinable topic, both for MCQ and for orals. So I'll plead with you people to kindly go through these slides. And also one thing that Philothea said, Wafoga will also ask you if it's either pre-excited or if it's a WPW, or if it's, of course, he was, I think he said, what about if it's an antidromic? Would you want to still give the adenosine? Of course, Philothea also said it in her presentation. So please just watch out for that. She gave everything. If you can get the audio of what she presented and play it in your car, and at the same time also, if you can go through the slides. I remember prior to this year, this description of what she gave very simply today. Almost every year, Prof. Oladimiji will come up to go over it again. But today, she has made it so easy, and then now we have captured it in recordings. So please, let's go through our slides. And I must really applaud Philothea. Philothea, please, thank you so much. This is a very brilliant presentation you just made. Thank you. And then the good thing is that you even added the guidelines, like you did a bridge, both guidelines and everything put together. Thank you. Well done.
Thank you very much, Dr. Kofi. Once again, thank you, Dr. Philothea. So we'll go off, then we'll do the MCQs. Thank you.